The topic is hollow viscous injury. Is there a time to repair? We are pleased to invite the Professor Yazumitsu. He's a professor at the Department of Traumatology and Critical Care Medicine, Graduate School of Medicine, Osaka City University. He's also the director of the Critical Care Medical Center and Intensive Care Unit in Osaka City University Hospital. Professor Yazumitsu, please.
Good evening, ladies and gentlemen. It is my great honor to join and speak in the webinar of the Asian Corporation for Trauma. I appreciate to the conference organization and the moderators for this opportunity. Today's theme I was given is hollow viscous injury. Is there time to repair in the damage control surgery? Before starting the discussion about is there time to repair of the hollow viscous injuries in the damage control surgery, I would like to remind what is damage control surgery. When we apply the packing into the abdomen, for example, perihepatic packing for the liver injury, can we say I performed the damage control surgery? When we finish the operation with the open abdomen management, can we say I performed the damage control surgery? Does the damage control surgery mean quick termination of surgery? These are the important aspects of the damage control surgery. However, the principle of the damage control surgery is not only these techniques, but the strategic resuscitation principles for the life-threatening trauma patient. It is similar to how to save the sinking warship. The effectiveness of perihepatic packing was first reported on 1981. In this article, 10 patients with continued hepatic parenchymal oozing following all surgical attempts were treated by the insertion of intra-abdominal packing around the liver as a last desperate maneuver. Packing was removed at laparotomy. 9 of 10 patients survived, and no instances of rebleeding following removal of the packing. This case series reported that intra-abdominal packing for control of hepatic hemorrhage appears to be a life-saving maneuver in highly selected patients. It was the turning of the surgical technique for control of hepatic hemorrhage from the repair or resection of injured parenchyma to control hemorrhage using the perihepatic packing. In 1983, Stone reviewed historical comparison of the surgical experience for the 31 patients who developed major bleeding during laparotomy. Management of the initial 14 patients was by completion of all facets of operation. The subsequent 17 patients had laparotomy terminated as rapidly as possible to avoid additional bleeding. Laparotomy parts were packed within the abdomen to effect tamponade, and the abdomen was closed under tension with drains or stomas. In the initial group, only 2 patients improved the coagulation function, and only 1 patient survived. In the subsequent group, however, the abdomen was re-explored in the 12 survivors, and the definitive surgery was completed. 11 of 17 patients survived. This technique of initial abortion of laparotomy, establishment of intra-abdominal tamponade, and then completion of the surgical procedure once coagulation has returned to an acceptable level has proven to life-saving in previously non-salvageable situations. In 1993, this strategy was named as damage control. In the conclusion of this article, the damage control is a promising approach for increased survival in exsanguinating patients with major vascular and multiple visceral penetrating abdominal injuries. Through these original reports, we can say the principle of the damage control surgery is treat not injury but physiology of the patient. The crucial aim of the damage control surgery is to stop physiologic derangement and do not add further stress which would deteriorate patient physiology. This is the damage control. Based on the damage control principle, which gives great importance on the patient physiology, we have to apply the procedures in the abbreviated first-step surgery. Since continuous bleeding makes a patient dropping into the hemorrhagic shock, followed by hypothermia, metabolic acidosis, and coagulopathy, we have to stop the bleeding using the simple and quick procedure. In addition, when the patient has a spillage of the bowel or the bile leak, these continuous spillage should be controlled. The contamination would induce the patient into septic status and aggravate their physiologic status. To control the contamination, is there any difference between leaving the stapled cut bowel in the abdomen and reconstruct the bowel with anastomosis? Since it is known that the resected bowel end can be left without reconstruction up to 3 days, the time-consuming anastomosis is not an option in the abbreviated surgery. When starting the damage control surgery for the intra-abdominal hemorrhage, crush laparotomy technique will be applied. That is rapid entry into the abdomen with large incision. The incision is long midline from sternum to pubis. Enter into the peritoneum within 1 minute using a scalpel and finger by the shown 3 steps. After opening the peritoneal cavity, we have to control the massive hemorrhage. For this purpose, scoop out as much blood as possible at first. After the blood are removed, eviscerate the small bowel out of the abdominal cavity and inspect the active bleeding from the visceral organ or mesentery. When active bleeding was observed, control it by the pressure of fingers. Using dry swabs, pack the abdominal viscera and get the temporal hemostasis by pressure applying. The crush laparotomy is a procedure that changes internal hemorrhage to external hemorrhage. Imagine how easily we can apply the direct pressure on the bleeding site and can get the hemostasis when the hemorrhage occurs on the body surface as the external hemorrhage. After getting the temporary hemostasis with pressure, stop the hand and keep on applying the pressure. Catch up the resuscitation with fluid and blood product. Get the required instrument for the following procedure and build up the resuscitation and surgical team. In the following procedures, it is important to treat first what kills the patient first. The most life-threatening is massive bleeding. After the control of the bleeding, we will examine all abdominal viscera. It is important to fully examine the whole region from the diaphragm to the bladder and urethra using the routine steps. For the full examination of ureteroperitoneal organs, several maneuvers are sometimes additionally required. In the patients of mesenteric and bowel injuries, massive bleeding occurs from the injured site of mesentery. Not clamping the hemorrhagic site widely, but open the mesentery and find out the bleeding vessel and tie it for the hemostasis. Unless the injured site is the root of the mesentery vessels, tying it up is allowed to get the hemostasis. After stopping the bleeding, evaluate from the stomach to the rectum and stop the spillage from the injured bowel. In emergency laparotomy, any hematoma on the stomach must be explored because it may be hiding a full thickness laceration. When an anterior hole in the stomach is found, search for a second hole must be taken. It must be assumed that an even number of holes should be created. The posterior wall of the stomach must be inspected by entering into a lesser sac through the gastrocolic omentum. Inspection of the gastroesophageal junction, the proximal gastric fundus, and the lesser curvature requires division of the ligament. If there is a hematoma on the duodenum, it is mandatory to expose and inspect the entire duodenum. The Coca maneuver with the medial mobilization of the distal ascending colon and hepatic fracture will allow the exposure of the first and second portion of the duodenum. Cutting the ligament of Tourette and mobilization of the duodenal jejunal junction allows for inspection of the fourth and anterior third portion. The right medial visceral rotation can be performed to improve visualization of the posterior and third segment, if this is necessary to complete a duodenal repair. Examination of the small bowel should be done systematically from each side with 2 pairs of hands. The ligament of Tourette should be identified and the small bowel examined loop by loop. Following brain trauma, small bowel injuries are generally obvious and are often associated with mesenteric bleeding and hematoma. In penetrating trauma, especially stubborn, small bowel injury may be small and easy to miss. This is the reason that all hematoma on or adjacent to the bowel wall must be explored. In the colon injury, mobilization of the colon is mandatory when hematoma is present. Inspection of the full circumference of the colon should be performed. After the whole injury inspection, we have to decide how to manage whole viscous injuries. The injured viscera, number of the injuries, and grade of the injury would contribute to the decision. In the damage control technique, adequate technique for the perforation of hollow viscous injuries is simple suture and rapid segmental resection using GIA staplers. For the stomach full thickness injury, the hole would be closed with 2-layer sutures. The first layer can help hemostasis, since the ongoing bleeding is common due to the vascularity of the stomach. The stomach is extremely difficult to narrow because it is capacious and will further expand over time. Anterior and posterior wounds near the greater or lesser curve are best treated by connecting the injuries into one laceration. This procedure makes the edge of the injury well visualized circumferentially and will ensure complete closure. This is a case of gunshot wound. 32-year-old male was shot in his left chest abdominal region. When he was transported to our hospital, his respiratory and circulatory conditions were stable. The monitored blood pressure and heart rate are shown on the slide. The chest X-ray showed no hemo nor pneumothorax. The bulge can be found in the abdominal X-ray image. After the laparotomy, small hole was found in the anterior wall of stomach. To inspect the posterior wall, opening the greater omentum, hole in the posterior wall was found. The bulge penetrated the pancreas body. While we were inspecting the hole of the pancreas, massive bleeding suddenly occurred through the hole. There was splenic vein injury. We performed the distal pancreatectomy and get the hemostasis. The edges of anterior and posterior holes were debrided and closed in 2 layers. This was not the damage control surgery, however, good practice of stomach penetrating injury. Even in the damage control surgery, it is crucial not to miss the full thickness injury of the duodenum. When hematoma was observed, the duodenum should be mobilized and inspected the whole sections from anteriorly and posteriorly. Even in the damage control surgery, the hole should be closed temporarily or permanently. This is inevitable even if the temporary repair results in significant narrowing of the duodenal lumen. With near transection, both ends can be oversewn or stapled. Control of the contamination is crucial to prevent severe inflammation in the patient who will need more laparotomies. When pancreatic duodenectomy was necessary in the high-grade injury, the injured site should be sewn or stapled shut. Closed suction drains should be placed. This is a case of stab injury in the right upper quadrant of 53-year-old male. When transported, he was in the profound shock status. Oral intubation was performed and the 4 French chest catheter was inserted from the right femoral artery. Emergency laparotomy was started within 20 minutes after the transportation. Through the right femoral artery, ear rescue balloon catheter was inserted and the labor was applied during the laparotomy. After the crash laparotomy, obvious amount of blood was observed in the peritoneal cavity. There was deep ulceration in the right hepatic lobe and massive bleeding coming from the cut and lacerated liver facet. While both hands pressure was applied to press the injured liver, the Pringles maneuver, liver inflation, started. The perihepatic packing was placed and fortunately, the massive bleeding was controlled even after the Pringles occlusion was released. There were grade 3 duodenum injury in the second portion, superficial pancreas injury, and grade 2 colon injury. The duodenum injury was closed in a single layer suture. The operation was finished with the abdomen open. Since the postoperative circulatory status was not stable, we had to move the emergency reoperation after 10 hours of fast operation. Massive bleeding occurred when the packing slabs were removed. The Pringles occlusion and labor were applied again. Every bleeding vessels in the lacerated liver were sutures. Horizontal matrix sutures were added in the both sides of lacerated liver to apply the pressure. Since there was small bile leak from the suture's duodenum injury, the previous suture was removed and the injury was sutured in the 2 layers as shown in the figure. After confirming the control of bleeding, the operation was finished with open abdomen management. For the management of small bowel and colon injury, while the inspection of the small bowel or colon, all injuries should be marked with a suture or Babcock clamp to decrease stretch, but no definitive repair should be made until the entire bowel is inspected. In the unstable patient undergoing a damage control procedure, control hemorrhage and contamination is the essential procedure. The damaged bowel can be resected or leave stapled or tied off discontinuity. When multiple injuries were found in the small bowel, consider about the length of the preserved bowel. There is no option for stoma formation in the damage control surgery. All macroscopic contamination should be washed out using copious amount of warmed saline before temporary abdominal closure. In conclusion, in the damage control surgery, it is crucial to treat the physiology but not the injury. To avoid missing the injury, it is important to inspect the whole bowel by the routine procedure. Control spillage from the bowel injury is certainly performed even in the abbreviated surgery and confirmed in the planned reoperation. There is no benefit to reconstruct the whole viscous injury during the damage control surgery. Thank you very much.